All right. Well, thanks everyone for joining us this evening. We do have some people still trickling in, but we will get started. So I will give a little introduction on Dr. Starr, our speaker for the evening. Just a reminder that if you do have questions throughout the presentation, you can enter them at the Q&A box at the bottom of your screen. You can feel free to enter them throughout. Dr. Starr said he will answer throughout, and then we'll take some time at the end as well. So just a little bit about Dr. Starr. Dr. Starr is the medical director of the Orthopedic and Spine Institute at Abington Jefferson Health and specializes in total hip and knee replacement surgery. He regularly lectures nationally on modern techniques for total joint replacement and frequently has visiting physicians observe him during surgery to learn the latest techniques. Dr. Starr sees patients in our Chalfont, Doylestown, and Willow Grove locations. Could take it from here, Dr. Starr.
Okay. Well, thank you very much, Natalie. I appreciate the introduction. And I just want to say how much fun it is to be here. Thanks, everyone, for coming on. It's really been very exciting for me to see the evolution of joint replacements from really what's kind of been the horse and buggy days when it first started in the 1960s. I wasn't practicing then, obviously, but now to where we have a lot of other new technologies and things that we should certainly talk about. I want to thank everyone for coming on. I'm excited to be here. I also want to acknowledge, so I'm a physician, part of the Rothman Institute, part of the Jefferson Health System. I work in 4 different ones of the Jefferson affiliated locations. So that's really where I'm living and what I do every day. And all I do is hip and knee replacements basically every week, all day long. So and evaluate patients obviously for that. So what I'm going to do is I'm going to share my screen, and it'll take me just a second, and then you'll be able to see my slides and see my talk, and then I can continue to talk. As Natalie advised you, if you want to put questions in the chat, please go ahead and do that, because there may be a moment during the talk where it sort of fits, and I'll just go right into that. So if you want to do that, that's great. So I'm going to share my screen here for a second. And bear with me one second. And then I'm going to put this up. Just take me a second. Okay. So once again, thank you very much. And the title of my talk is Modern Hip Replacement is Different, Better. And I think we really have to look at some of these newer technologies that we have, because they are really tremendous technologies. But at the same time, we have to evaluate them in the context of, are they proven? Is this something that we really want to do right away? Or is it just right for certain patients more than others? But, I'll give you some information about it, and then you can judge. This is what we look like when we're doing a total hip replacement. And this is what we call a spacesuit. It's not really a spacesuit. It's a suit that isolates the surgeon from the patients for the purpose of protecting the patients from bacteria. And you can see here, right just to my side here, there's a computer screen, and that's kind of what we're going to talk about tonight, which is that it seems like technology is everywhere today. We have computers on our laps, and we have cell phones that have computers, and basically that's where we are today. So I have some biases. I like to put these out right at the beginning. I do some work for DePuy, which is Johnson & Johnson's company, and Radlink, which is one of the companies that makes some of this technology. But more importantly, I've been committed to technology for many, many years. Technology came out in total joint replacements sort of in the early 2000s was when we started to talk about using computers, using different kinds of implants, minimally invasive surgery. And I train residents and fellows and medical students all the time there in our hospital all the time. And I'm very committed to this, and it's part of the fun of having these young brains in front of me who really think along the lines of technology even more so than some of us do, and it's exciting to see how they really kind of rise to this. So we're going to talk today about technology and some of the things I love to do. So just basically, what's a hip replacement? Well, I want to kind of level set everybody and give you an opportunity to understand what a replacement is, so we're all sort of on the same page, and how that's changed over recent years. So I always get a kick out of it because this is a picture of a hip replacement, and you can see there's a metal stem and a metal socket. In this case, there's a metal ball and there's plastic in between. You can actually see a little screw peeking through here. And the hip replacement, often the first time the patient actually sees their hip replacement is at their post-op appointment a month or two after surgery. And I always get a kick out of it because I've had surgery as well. And it's interesting, if you've had surgery, to sort of think about what your experience is and what you feel versus what you see. And it's very dramatically the case with this type of surgery, whether it's a hip or a knee replacement, because we put fairly sizable components inside people's bodies. And the most interesting comment I always get is, wow, it doesn't feel like that. I don't really know that that's there. That's certainly more true for hips than knees. But most patients don't even know they have it. And sometimes they sort of forget which hip we fixed, if you ask them a year or two later. So I just think that's sort of a fun part of it. Now, when you look at a hip that's failing or there's a problem, and this is what we want to try to avoid, if the ball comes out of the socket, you're certainly going to feel it. So, you go from a well-functioning hip replacement to one that's going to dislocate, which does happen, but it's very rare. But it does show you that, when all is good, they usually work well. When something is not great, when something goes wrong, then the patients become very readily aware of it. So that's a hip replacement. Now, why are we here today talking? Well, let's sort of set the stage here a little bit. And that's that, I used to show this picture years ago, and these were just a bunch of things that I received in the mail as advertisements, actually from places all over the country. A newspaper article from Florida talking about these spacesuits and great ways to do joint replacements. And then you have Penn, and you had, our place at Jefferson, and places like Hospital for Special Surgery out of New York, Hennepin County Medical Center, which is, many miles from here outside of the state. And so there's a lot of effort being made toward letting people know that there's new technologies, new ways to do things. A lot of this is no longer being done via mail. We're in an internet age, and it comes on the internet, it comes on your phone, social media. So there's a tremendous amount of conversation. And, what are patients asking me about? What are they hearing about? Well, they're hearing about robotics. For years, we've talked about minimally invasive surgery. What is that? And they've heard about anterior hip surgery. So let's kind of take a little look at that and see what we have. So this is some marketing. I X'd out the actual folks that put this, but this is an advertising and marketing piece that's on the internet. And I want to point out a couple things here. So this says XXX offers these robotic hip surgery using Mako. That's one of the brands of joint replacement surgery. Look in red here. It says the robot enhances your surgeon's expert skills for even more precise procedures and the best possible outcomes. Go down the bottom. A robot's precision surpasses the human eye, and that precision helps surgeons tailor their procedures, which can lead to optimal recovery after surgery, helping you get on your back feet and return to everyday activities. And this goes on to talk about optimal type and placement of your joint, and it helps ensure a more natural feeling joint replacement. And, this is a very credible institution that advertises this. And there's multiple, if you go across the country, a very high percentage of places will advertise and talk about technologies. And the only thing I can tell you is that, and I'm a big advocate of robotics, we're going to talk more about that. Most of these claims have never been proven. Surgeons have confidence in these technologies, at least some do, and they feel like it may give them some better information in order to do a better hip replacement. But to date, most of these claims are unsubstantiated. So, just because something's new doesn't necessarily mean that better, even though I do virtually every one of my joint replacements with some sort of advanced technology. So I'm an advocate of it. I love it. I think it gives me great feedback, but I can't really say to you that somebody who's a very qualified surgeon who does a standard joint replacement is not doing as good a job. So I apologize for that, because I really wish that they would. Now, I think this is sort of the crux of it is, the internet and social media. I love the internet and social media. A lot of surgeons don't, because they get a lot of questions. but I like it. Now, it's always information, but it's not always education. I think there's a big difference. You're going to hear a lot about things on the internet, but it's not always things that are validated or considered generally accepted. But that doesn't mean you shouldn't look. And I think it's always good to see what's out there. And then, use your sources, whether it's research, whether it's talking to experts, whether those are physicians or nurses or other people that you might know. But I do think this is very valuable. So once again, what are people talking about today? Well, minimally invasive surgery, which was popularized actually on 2020 and 2001 by a Dr. Berger from Chicago, was really what got us started in this. And then robotics and anterior hip surgery. So we're going to talk a little bit about those things in the next few minutes, and then we'll have time for questions. So how popular are these questions? Well, if you go on an internet search engine and look up anterior hip replacement, in a matter of seconds, you will get 793,000 results. Robotic knee replacement, a paltry 544,000, and minimally invasive hip, 483,000. So thousands and thousands of people are talking about this. And actually, when I did this several years ago on various search engines, in some cases, it was well in excess of 1 million responses to these types of words and questions that people have. So it's very, very popular. Well, let's kind of get everybody on the same page. So, we're dealing with the treatment of arthritis. Arthritis, most people would describe as, grandma's rheumatism. I'm stiff. I can't move my hip well. I'm out of shape. I have atrophy of my muscles. These are all the things that you see with arthritis. What do I see as an orthopedic surgeon besides the symptoms? Well, inside, you can see nice, smooth cartilage. This is a hip joint. And these are pictures from the American Academy of Orthopedic Surgery. And it's a great place to go. I'll give you a reference for that on the online for information. This is the bone, a cross section. This is the cartilage, and this is the bone of the femur. So this is the socket, and this is the ball. When you get arthritis, it kind of looks like it's rusting. It wears out. You get little pock marks in it. It doesn't look right. And that's what you have. So now you have, instead of smooth on smooth, you have rough on rough. And that's what leads to the arthritis or the inflammation. The way that I see this usually initially is on an x-ray, which you can see the bone is flattened on the top here. There's actually holes in the bone. It gets a bit like Swiss cheese and it turns white like this. So that's what arthritis looks like to the orthopedic surgeon on an x-ray. This is another one of those pictures, just a great place. The American Academy of Orthopedic Surgery is the place that the vast majority, it's a professional organization for the vast majority of orthopedic surgeons. You can go on it by typing in aaos.org, and there's tremendous information showing the socket of the hip, the femur bone, the femoral head, the pelvis, how everything fits together. And you can look up shoulder problems and foot problems and all sorts of other things. It's a great place for information, and it does encourage the public to go online. This is once again what an arthritic hip looks like. Look at how rough this is. You can imagine it's not going to feel good when this is moving. And here's how we see it on an x-ray. This is a normal hip, which is round, has cartilage in between, so there's a space. And this is the narrow joint space of a hip arthritis patient. Now, arthritis is very popular. This is statistics from many years ago, but 12% of people aged 25 to 74 have this. We spend billions of dollars a year, both in lost wages and lost activities, as well as in taking care of patients, and 427 million days of restricted activity a year. These numbers are older numbers. At that time, we were doing 240,000 hips and 400,000 knees. It's about 50% higher right now. So we're doing upwards of 1 million joint replacements, hips and knees a year. Very important. Why do you get arthritis? Well, some of it is it's genetic. Your mom had it, your brother had it, your sister had it, you're going to probably get it. Injury causes a lot of arthritis. We've seen some recent severe injuries in the football arena, and those folks are going to probably become arthritic later on. Very heavy people tend to get it, and people who are excessively active, the ultra marathon runners, people like that. Some get away with it, but they're more likely to get arthritis. Or somebody who does heavy physical work all the time would be even more likely. How do we improve pain? Well, the first thing is if you have arthritis in your hip, the first thing the doctor shouldn't talk to you about is having a hip replacement. They should talk to you about reducing weight, building up your strength, which improves the symptoms of arthritis. I think it takes the pressure off the joints. You can take typical over-the-counter pain medications, anti-inflammatories, Tylenol, things like that, and those can be very helpful. But obviously, those are the standard treatments. If they don't work, then you have to think to yourself, what do I do now? Should I get my hip replaced? And just so you understand what a hip replacement is, it's an unusual kind of surgery. Most surgical procedures are repairing things. Replacements are truly replacements. You're changing tires. So I always use that analogy because I'm explaining to patients that we don't have to fix what's there. We're not going to repair it. We're going to literally take out the parts of the joint and put a new hip in there. So it's like your tire can get pretty worn out. You put a new one on and it's brand new. That car drives like it was supposed to and like it always has. So that's a hip replacement. It's a very different concept from what many other kinds of surgery would be. So let's look at what we put in there. This is a typical replacement. It has a titanium stem, a titanium socket. Those are what attach to the bones. It has a ceramic ball and a plastic socket surface. So that's what moves. And eventually that plastic's going to wear out, which is what leads to the hip ultimately becoming non-functional, having to do over. This is how it fits in. The stem fits down in the bone. The ball and socket fit into the socket. And, it's about an hour surgery in many doctors' hands, and we can talk about that in recovery. This is a close-up of the actual implants. There's the titanium surface. It's rough, so the bone can grow into it. This is the roughened surface of the stem, which allows the bone to grow into it. In this case, this is a ceramic liner. You can get plastic liners and ceramic balls. So, there's slightly different nuances, but this is the typical replacement that most of us use. And once again, we're really just we're fixing that old tire. We're throwing away the bad tire and putting a new one in. So now what about how patients are doing? And this is super important because when you look at a hip replacement patient and you say, we're going to tell you you should do something different, we have a new kind of replacement, we really need to look at the patient's satisfaction with the old replacement. So this is a paper that was written I'm trying to think when this was done. I'm sorry, 2012. So this is about 10, 11 years old. And the satisfaction, you can see the 100% satisfaction means that the patient checked off the top box on the satisfaction survey. And the vast majority, over 50% of the patients said they were extremely satisfied. Those who were not extremely satisfied were very satisfied. There's very few down here that are not satisfied with their hip replacements. So before you go changing something, you have to say to yourself, what are you starting with? Also, how long do they last? Well, there's a number of studies that look at this, and 60 to 80% last as much as 25 years. That's an awfully long time. So what we've done for the last 25, 30 years in hip replacements has worked. So we're making it better. Now, some things we try to make better, and this was a type of replacement that was developed about 15, 20 years ago, which was a metal on metal hip, no ceramic, no plastic, metal on metal. And these worked very well for a short time, but then the leaching of the metal and the wear of the metal would get in your bloodstream and into your joint and do a lot of damage. So we have to recognize that anytime we change something, there's an upside and a downside. So what do we know about technology? Well, there's old technology, which we know how they work, right? So I can tell you the statistics on an artificial hip today. But you may say, well, I don't want a hip that's going to last me 20, 25 years. I want one that's going to last me 50 years. Well, the problem is the older stuff, we know how long they last. And they may not be as good as you really like, but any new technology takes a long time to be proven. And oftentimes you hope it's better. It may be worse. A lot of them are better, but a few are worse. And some, as in the case of the metal on metal, can be very bad. And, we've had to reoperate on a lot of patients from our place or from other places that were referred to us for these types of hips. So, but the problem is, how do we make progress without trying something new? So you have to decide as a patient, do you go with the standard, which somebody feels comfortable with, or do you start looking into new technology? And the first question you should ask is, how long have you been doing it? How are they coming out? Now, we'll go into some of the newer technology. So in about 2001, here's our typical hip replacement. We started to do minimally invasive total hips, which in those days really amounted to the same cut on the buttocks, on the butt of the patient, where we have to go through a lot of muscles, the gluteus muscle, etc., done through a smaller incision. Now, there's still a lot of people that do this, but I think the point of this is that in all the years we were doing this, the patients kind of liked them better because it was a small incision. I'm not sure the patients really got better any faster, but it was a nicer way to do the surgery and, was cosmetically made the patients happier. And, I think if you feel better about the type of surgery you're having, then you are likely to feel better about yourself and how you feel. And this, in this case, was a 7 centimeter incision. This is not inches. This is about 2.5 inches. Right. So the concept of the minimally invasive total hip surgery, for the reasons I just mentioned, remains controversial, and it involves a lot of factors. Right. And the fact is that people associate minimally invasive surgery with what they probably should associate with it, which is feeling better more quickly, getting out of the hospital more quickly. Well, some of that we're doing just in general. Now, I do all my surgeries through small incisions, but I will tell you, I think what's more important is we are better at pain management. We get the patients much more comfortable by using what we call multimodal protocols. So we attack the pain from different parts of what makes pain, the neurological, the inflammatory, the pain fibers themselves, etc. So basically, pain management programs have made it so my patients go home sometimes the same day as surgery. Rapid recovery programs, we know that we don't have to baby these implants as much as we used to think. So we get the patients up with therapy and get them doing things. The other thing is just we as a society have shifted our attitude. And patients, particularly since COVID, they don't want to be in the hospital. So they're looking for ways to get out of the hospital and get themselves back on their feet. Their expectations are they want to go back to work. They want to go back to their lives. An elderly person wants to go back to their life and the things they enjoy doing. A younger person wants to get back to work. Surgical expertise, very critical. We're clearly learning better how to do these surgeries safely. You notice I listed technology last. I think technology will be an important part of what we do, but it's only one of many things that are involved. And, I get asked this question a lot when I give these talks, and they say, well, you don't seem like you like technology. No, you're looking at someone who loves technology and uses most of the advanced technologies every single day. I did 6 robotic knee replacements today and 2 computer guided hip replacements. So I use this technology every day, but I also try to be realistic about what it offers. And I think we're learning from it, and we'll see the role refined over the years. So let's talk a little bit about the next technology thing that people talk about, which is, well, we don't do the surgery as much through the posterior, through the buttocks here. This is a side view. We're now doing it from the front a lot more. The theory being, here you're cutting through more muscles, here you're not. I think that may be part of it. I don't know that that's ever been 100% proven. Certainly, my personal experience with anterior hip surgery has been, not only myself have told me this, but people I've either taught or encouraged to learn anterior hip surgery who previously did the other versions tell me that their patients are happier. Now, that isn't very scientific, but clearly the anterior surgery is a way to do the surgery going through muscle intervals between muscles rather than through the butt. And the patients do seem to get up and get moving quickly in my hands. I'm biased. That's how I do it. This is another view of how we get to the hip. And you can see that from the front, you're really more directly into the hip joint. The ball and socket are right here. From the back, that means posterior, you're going through more tissue. So I do think there may be some interest in that. The other thing is that what got people interested in the anterior approach as well as the recovery was that it's done in a unique way. Now, not everybody does it this way, but the majority of the hip surgeons over the years have done it on a special table. And this table is designed so that we can position the hip in such a way, and it looks terrible, right? This is a model who's awake. She's not uncomfortable, but it is a way to get access to that front area during the surgery. The other thing about it is we can take x-rays while we're on this table. And we do that as we're doing the surgery. You can see here, we use this special OR table. And in my case, I always take x-rays during the surgery and then put it into my computer system and measure things like the lengths of the legs and other things that patients are interested in. So that's anterior hip surgery. I have a bunch of colleagues that don't use this type of computer system with x-ray, and they do a great job doing anterior surgery. I do think the image guided version with the measurements and everything we do helps me as a surgeon. Clearly, there's a lot of people who do an awesome job, several of my associates, without all this technology, but I just feel like this is information I like to have when I'm treating my patients on things like leg length. Does this mean that everyone's legs are going to be equal when you do it this way? No, but you get a lot of feedback. Does this mean the implant's going to last longer? We don't know, because you have to study for 25 years to see that. And, are we putting the implants in the proper sizes because we can see them? That's been my experience. But once again, much of this is not proven. And what's talked about a lot with some of the newer technologies is that the patients, I don't recommend you do this, but what patients talk about is they want to be able to sit on a normal chair, tie their shoes, go back to work, and they don't want to have to worry about the hip dislocating, which is one of the concerns with some of the other techniques. They want to get back, they want to drive. We used to tell people you can't drive, we can't, be careful on the stairs. But remember, some of the change has been driven by changes in general techniques, like, overall better techniques of any type of surgery, as well as um, not telling people to do things that aren't necessary. We used to worry that the implants would come loose. Now, I don't let my patients do this in the first 6 weeks, but we certainly can let them do some modest exercise very early on with any of these techniques. So the results after hip surgery, if you look at the literature, if you look at the papers that are published, here's one from the Mayo Clinic, which is, I think, reasonably well regarded, 2018. They showed a slightly faster recovery of function in the first few months. And then after a few months, they didn't see a big difference. I think most people say that all these hip surgeries are successful in the majority of cases. Most surgeons have their preference. Best thing to do would be to ask the surgeon about it and see what appeals to you as a patient. So in conclusion, anterior hip surgery, it remains controversial in the sense that some people say that it's better, some people don't, but it is an accepted procedure. It's not experimental. It's been around. I mean, I've been doing it for 16 years. All of these approaches, posterior, anterior, and lateral, which are different ways to put the hip in. I'm going to steal from one of my patients who said to me, you do the same procedure, you just do it in a different location. And that's true. We just get there in a different way. But the most important factor in your care is your participation, what you do to make yourself better, as well as the expertise of your surgeon. And then last but not least, robotic hip replacement surgery. I have to give some credit to the Houston Astros. This is them after they beat our Phillies, which makes me upset. But, is this going to be the champion of surgery? Well, we're hoping, but I'm not sure we're quite there yet. One of the questions I get asked all the time, we wrote a paper actually where we surveyed a bunch of patients, my colleagues and I from Rothman. And one of the concerns people had was, does the robot do the surgery and the surgeon's not going to do anything? And that's clearly not the case. These are not autonomous robots, like you saw in the old science fiction movies. These are robotic tools. And if you look at them, you probably wouldn't call it a robot. and I'll show you a couple pictures of it. The other thing is all robotics use computer guidance, but not all computer guidance uses robotics. So computer guidance is measuring things during the surgery. This is an X-ray based system that I use for hips, but it's measuring things during surgery to make sure that you're getting the results you want by measuring leg length differences and offsets, things like that. And I use this as a tool. It is not something everybody uses. It's not necessary for every surgeon, but I do like the feedback I get from it. But it's a way of making measurements. The robots don't use X-ray measurements, they use another technology. But this is what a robot looks like. So it doesn't look like something that's going to walk into your room. This is one of the few hip robots on the market. There's a lot more knee robots. And if you notice, there's a tool here with a trigger, which the surgeon has to operate. I'll show you more pictures in order to grind and prepare the bone to put the implants in. So that is a robot. That is an orthopedic robot. That's how they work. This shows you a little more parts of it, same robot, but they all have computers. That's what does the navigation parts of it. That's what helps you to design. And that's what I like about these systems. I can design how I want the implant put in, and then I can achieve it, whether with navigation or computer guidance. So I think these are, I'm sorry, navigation or robotic guidance. And so actually this is all in the operating room when you're working, and you're working with a computer screen as you're working and doing the procedure. This is some of the additional information that we see. So this is done before surgery on the basis of CAT scans or X-rays. And these are the cross sections of the bones. And we're designing here with these green pictures where we're going to put the socket, where we're going to put the ball, and in what positions. And that's what it does. And it watches us as we're working. In the case of the hip robot, as we drill, this actually shows the drill in the socket as you're doing it, and it tells you, what you're trying to achieve. Excuse me. I double clicked. Here's what it looks like. Here's the robot arm, and this is the surgeon operating it. So the surgeon is not walking away from this thing. And this is the same thing when we put the actual socket cup in the bone. We're using a device to impact it into the bone. You can see that here, and it's connected to the robot as well. So the robot controls, and this is the technology we use. We have these things we attach to the patient. These are little reflective markers that the robot can see and tells us where we are based upon looking at these things and comparing it to the plan. Right, so the robots really make a difference. We're all a little confused by this, by the way I presented it. Well, we really don't know. We do know they're more accurate. Multiple studies say that robots put implants in a picture that makes the X-ray better. But do the patients really feel better? That really remains to be proven. And that's for any joint replacement, hips, knees, and partial knees. Even though I do every one of my knees and partial knees with a robot, that is just the fact of life at the present time, which is that a lot of surgeons like it. They like the way things come out, but the patients don't come in and say to us, oh, this is, much different than my aunt or my cousin who had a replacement. In spite of that, technology is increasing at a very rapid rate. Here's a study that talks about the use of technology in various centers and for different kinds of patients. And you can see that the numbers are increasing markedly, particularly for joint replacement. Knee replacements now are certainly much higher than 12% using robotics. Does that mean we should do it? Well, I think I've explained to you that we're not 100% sure, but it is a technology that people are interested in. So I do think it behooves us to learn about these things. So in conclusion, before we get to some questions and answers, technology for hip replacements is very likely to continue to increase. Why is that? It's getting cheaper. It's becoming more miniaturized. Things like artificial intelligence and virtual reality are going to become very, very prevalent in our operating rooms within 5 years. Most importantly, you and your surgeons are what's going to make this successful. If you go into a surgeon with a notion of what you want and ask a lot of questions, that's great. But, listen to the person with experience, check their reputation, and really get their sense of how these things fit in. At the present time, there's no specific guidelines regarding the best way to perform a hip replacement. Now, I've already told you I'm biased. My very biased view is that I prefer using technology. I like the information and feedback that it provides, but I could create a panel with myself and my partners, and you'll get a bunch like me, a bunch in between, and a bunch that say it hasn't been proven yet. Why are we using it? It costs more. It doesn't cost the patient more, but it does. There is a cost to technology in terms of the institution. So I think that, that pretty much is what I wanted to start with. And I think the questions and answers, we can certainly come up with, some additional information that hopefully will be helpful to you. So let's take a look at this, some of these questions. All right. And I'm not going to mention names, and I'm going to keep things fairly generic so that they maybe apply. So let me read the first question. So I have mild hip dysplasia on the left side. That means you were sort of born with a hip that maybe doesn't work perfectly. It's causing discomfort, limping, problems sleeping, and I can't walk more than a mile, and it gets very sore when I do. No arthritis noted in x-rays. I'm 47, and I've had physicians talk to me about going in and trying to readjust the position of the socket so that the spurs and things that are bumping into the bone can be removed and make it more comfortable for me. So this is really a technology to try to prevent a hip replacement down the road. Fortunately, we have these technologies. Unfortunately, it's a controversial area. I do think there's a role for this. But really what you're doing is you're trying to do a big operation. It is a pretty sizable operation to try to, in the hopes that down the road, the patients will not get arthritic and that they'll feel better. I don't do this particular procedure, although certainly I've had a lot of patients have this sort of thing. I would say, you need to I would, in my opinion, get a few opinions about this. I do think there's a role for it, but so much of it is related to how the patient is selected, who does it. And, that's a statistical probability. I can tell you that, hip replacements are in the range of 90 to 95% successful, pretty well proven, pretty accepted. These types of surgeries are a little newer, so you have to go to see someone who you trust, and like I say, get opinions and see what the consensus is. Because, it's a lot easier to suggest this procedure to somebody who clearly is not arthritic and is younger. There's an age at which we don't do these procedures, and that's as people get older. 47 is pretty young in my book, but these are all factors to consider. Next question. Is the post-surgical recovery time any shorter after a redo of a former hip replacement done years before? That's one of those things it's one of those answers that I have to say it depends. Sometimes we just go in and literally just change that plastic that's in the socket. And a lot of times you can do that actually. We use these smaller incisions and things like that. And I would say that the way surgeries were done many years ago through big incisions and a lot of cutting, and the skill level of the surgeons has certainly improved over the last 20 years on the techniques, so that you may be able to have a surgery that's actually a little easier and go home the same day, depending upon what needs to be done. Now, if the whole hip has come loose, that's going to be a big surgery and probably going to be a longer surgery recovery time. So it depends a lot, but that's a great question to ask your surgeon, because there are different options depending upon how the procedure has failed. And saying it's failed sounds terrible, but if you wear out the plastic in 20 or 25 years because you had a great life and you could play pickleball and tennis and do other things, well, it may be worth then having the plastic changed if that's all that's necessary. Sometimes it's something worse and you may still need to have it, but that's really a discussion for an individual patient. Next question, and these are great questions. Do I personally do more hip or knee replacements? I personally do almost exactly the same number. And that's a little atypical. I would say most joint replacement surgeons, and we talk about a joint surgeon traditionally as a hip or knee surgeon, although there certainly are a lot of surgeons now, shoulder surgeons doing shoulder replacements, hand surgeons doing finger replacements, ankle surgeons doing ankle replacements. We got there first in hips and knees, so we kind of, took that expression. So if you look at the typical joint replacement surgeon, they do about 2/3 of their practice will be knees, 1/3 will be hips. With my interest in anterior hip surgery, my knee practice has stayed the same, and I do a lot. My hip practice has doubled over the last 15 years since I started doing some of these other procedures. So, that's unusual. How do I differentiate the complexity? Complexity of the surgery is very similar. I mean, it's the change of tires analogy. I mean, it isn't any harder to do one than the other for the surgeon. Clearly, in my experience, and this is not every patient, clearly in my experience, the average pain and recovery from a hip replacement is less than that of a knee replacement. Knees hurt more. Although having said that, one of my patients I did this week has told me she has absolutely no pain. And we certainly do get a fair number of those patients. The one thing I will tell you is within reason, the technology to treat pain has vastly improved, and we certainly can ensure patients or assure patients that we can deal with their pain, even though they're going to have to accept taking some medication for a period of time. And the other question, sort of the extension of that, is that a lot of patients, and rightly so, they come in and they say, I don't want to have surgery because I don't want to become addicted to narcotics. My philosophy is that my patients need pain medicine at the beginning, and then after a period of time, we have to accept that, the risks of taking these medications outweighs the benefits. So usually by 6, 8 weeks, most people are off the pain medicine. I really do not see the problems with narcotic use and abuse. Now, I think I have a lot of very nice patients, so maybe I just aren't seeing those patients, or maybe they're not telling me. But I know that we're not renewing pain medicine on our patients for months and months and months. And I think it is definitely safe, in my opinion, just my personal opinion, to have surgery and need pain medicine. And I encourage the patients. One of my colleagues who's a doctor told me after his hip he wasn't going to take any pain medicine. He wasn't going to need it. The next morning he called me after the surgery. He was doing fine, but he said, would you mind prescribing something for me because I think I need it. So, we have to have realistic attitudes about it. But in general, the hips are easier on the patient than the knees, but not in everybody. Next question. Pros and cons of a plastic versus a ceramic ball. The balls are actually not made of plastic. There's two options for the balls. One is metal and one is ceramic. Not a huge difference between them. There's some technical reasons that the surgeons prefer the metal, having to do with the very small likelihood of some corrosion underneath the metal ball. So we have switched the vast majority of our patients to ceramic. Now you then have a choice on the socket side to have plastic, ceramic, or metal. I mentioned to you that the metal's not very popular because of, what I told you about metal implants, rubbing on metal. Plastic is by far the most popular. There are some surgeons who prefer the ceramic in the hopes that they won't wear out as quickly. It's here or there we see them. I do a few of them in very young patients, but it's not something that has really been shown to be tremendously advantageous, mainly because the plastics are getting so good and go, 20, 25 years for a lot of patients. Next one's a little bit of a long one, but I've been experiencing pain in my right hip for a few years. I've seen 2 doctors. One feels it's arthritis. The other believes it could be a labral tear. X-rays, MRIs, etc. have been taken, and all they see is a slight thinning in the joint. And both have recommended a hip replacement. Physical therapies help, but I can't do my normal day-to-day activities like exercising and walking. My question is there something else, a test of some kind that can be done to specifically determine what the problems is? I'm not against the total hip, but I would like to see some evidence. And I'm 63 years old, in good shape, and don't have any arthritis in my family. Well, these are the most critical cases that you really have to go talk to your doctor about and spend the time with him or her to really understand what the options are. You've had x-rays and MRIs, which certainly are the best tests out there. Occasionally a patient will have a bone scan, not a terribly reliable test, but sometimes can help. And I think sometimes, and you've had this for a couple of years, um, sometimes there's a point at which you just have to look at the patient and say, you know what, I'm going to need to follow you for a little while and see what the progression is. Slight thinning in the joint would certainly not be something I'd be rushing into surgery. By the same token, and the labral tear, most people's labrum, that's the cartilage at the rim of the socket, tend to deteriorate as they get older. And so labral tears are things that in young people will often be treated arthroscopically. In older patients, they're just a part of the arthritis. And ultimately, if it's too painful, they have to have a hip replacement. It sounds like you're having some impingement or something like that where something's catching. And, the problem is a hip replacement may help that, but, it's a lot of surgery to go through. And so, you're going to really have to ultimately get some opinions and find somebody you trust and, take their advice based upon their experience. So those are tough. And, that is, those are things really to talk about and think about. Does Medicare cover robotic hip replacement? It's a knee replacements. Medicare covers joint replacements. I don't know that they pay any differently for a robotic hip versus a robotic knee, but suffice it to say that you're covered for the surgical procedure in the vast majority of cases. Patients have co-pays and co-insurance and other sorts of things, depending upon what their insurance is. But this is a very standard procedure. Are there any technologies for patients who've had prosthetic joint infection and, have had a hip replacement at the age of 56? There's a lot of things coming out in the area of infections in artificial hip joints. Infections in artificial hip joints can be pretty bad, and they will often lead to taking the joint out or having to do major surgeries. There's a tremendous amount of research into trying to develop molecules you can put around replacements to try to prevent infections, to put using different kinds of technology and biotechnology to try to find things that can attack the membranes that these infections hide in. Um, Stay tuned. There's a lot out there, but there's nothing I can say to you today. Okay, we're 100% convinced we've solved this problem. This is a great question I get asked a lot. Is the femoral bone marrow removed so that the stem implant has a place, and is some left in place? That's a really sophisticated question and a great question to ask. There's a lot of marrow in your body. When you're a little kid, it's all working hard to, make you create more blood and such. Most of the marrow that's left in the long bones, like the femur, the tibia, and the humerus, is fatty marrow. It's mostly fat with just a few blood forming cells in it. So the amount of marrow that you remove when you put that stem implant in, and thank you for asking this. It's a very common question, is really inconsequential and doesn't really affect your ability to maintain your blood count. Let's keep going. How do you suggest one addresses the concern of losing weight in order to have hip replacement, but the pain prevents the patient from being able to exercise and losing weight seems impossible? That's a question I get asked all the time. It's a great question. And, being heavy is a compromise. If you look at the statistical probability of an infection or a complication, depending upon how heavy you are, that risk can go up 3 or 4 times. So if it's a few percent, it can go up to a much higher number. So we know what we'd like, which is, healthy patients, just like any of the things we ask patients to do. Have your diabetes under control, stop smoking if you can. I've had great success with nutritionists and dietitians to help people to understand what they can do to lose weight. But it's not an easy thing. And a lot of times we'll sort of look at this from the standard of a patient who needs the surgery, and maybe the compromise is they don't lose weight till their perfect weight, but maybe they can lose an intermediate amount of weight. I have pretty good success with this, but you're right, not everybody's able to do this. And, we do our best to try to make those compromises and help the patient to make the best decision. Great question. Can you start with hip physical therapy, put off and delay hip replacement in an active 66-year-old? I can still walk 3 miles a day, and I have some pain only after bending, running, or after carrying a grandchild, then recover with minimal symptoms. You didn't say what your x-rays look like, but I'm going to use the example of somebody with arthritis and having some medium level symptoms like you're saying. And I always tell the patient several things. I tell them, there's three choices when you have hip arthritis. You can ignore it because it's not going to kill you. You can treat symptoms with things like therapy, injections, braces, canes, chiropractic, acupuncture, medication. And, I think people who are interested should try any or all of those. I don't recommend one over the other, but I do think those are things people often try. And when it gets bad enough, they generally will have their hip replaced. In a 66-year-old, you don't have the age issue. So a hip can last 25 years, 20 years in most cases. So a 66-year-old's probably going to have one hip replacement and, keep that the rest of their lives. By the same token, they don't have to have that hip replacement at any time in the near future if they don't want to. So, but you also have to look at the age factor. A 66-year-old, in my opinion, is not so old that we need to start thinking about a day soon where we might be more hesitant to do surgery. So I think of maybe a 75 or an 80-year-old who's starting to lose function, and we have to say to them, well, if you're going to do something, do it soon. If you're going to try to live with it, then fine. But when you have somebody 66, I would say to you, do what you feel comfortable doing, and, don't have it until you really think you're ready. Next question, a great question, because we talk about this always. Why don't they just do a hip replacement with femoral neck fracture? So when you break your hip, why don't we just fix the hip with putting a new hip in there rather than trying to put pins in or screws or rods or things like that? That's a question we talk about all the time. And I'm just checking my time. I think we're doing pretty well here. Broken hips respond better or worse to different types of treatments depending upon where the hip is broken, how old the patient is. So you mentioned in your note a femoral neck fracture, and a high percentage of femoral neck fractures are treated with some kind of implant, whether it's a total hip, which is the ball and socket, or just an artificial ball, which looks like basically the ball and socket part without the socket, a little larger ball to fit in your socket. There is no absolute right answer for that, but we certainly do at our center. A lot of our patients are getting femoral replacements or hip replacements rather than having a lot of pins and screws. Now, if the fracture is an inch lower, then it's not a femoral neck fracture, and those patients don't respond as well to implants. So they're getting rods or screws or things like that. Because just because you have a hip replacement, when you have a fracture, it's a very different recovery in my experience. I did one of these yesterday for a lady who was active and fell playing pickleball. And just because you've had a fracture and then have a hip replacement, my personal experience is it's a longer recovery and somewhat higher complication rate. And that's because you create all the inflammation with the fracture. And then when you go in there, you have all that inflammation already started. So your chances of having a problem go up somewhat. So it's not just a, clear-cut thing that we can do. It's something that, once again, you have to talk to an orthopedic surgeon that you trust. The problem in these cases is clearly that you fall and break your hip, you're in the hospital. And, you have to then make a decision fairly quickly. The other thing you asked was what percentage of these repaired hips go on to total hip replacements. It's actually a relatively small percentage if you're choosing the right patients to have this type of surgery. We do an awful lot of hip fracture surgery, and we do certainly revise a reasonable percentage of them to total hips, but it's not like it's 30-40%. It's certainly a number much smaller than that. So I think I covered most of the questions that we've had tonight. And so I think at this point, we'll close it out for tonight. I really want to thank everybody. These are great questions, and really, we very much appreciate your signing on and watching us tonight, and having the opportunity for me to talk to you about really something I love to talk about, which is this technology piece and, how we can help patients. So I will sign off for this moment, wish you all a good night, and ask Natalie if she has any other final comments.
Yes, thank you, Dr. Starr. Wonderful presentation. I did have a few questions come through about possibly making an appointment with you. I did privately respond to those, but for anyone else who is considering making an appointment or needs assistance with that, you all have my email address from the reminders for the presentation. So please feel free to reach out to me. Happy to help facilitate that. Also, just a reminder that we did record this presentation tonight, so we will send that out probably by the end of the week. So if you attend it, or if people who registered and last minute could knock it on, we'll receive that as well. So thank you again. Thanks, Dr. Starr, as always, for your wonderful information. And thank you everyone for logging on tonight. We appreciate it.
Thanks, and have a wonderful evening. Good night, everyone.
Good night.